Welcome back to The Explainer. Today, we're doing a deep dive into the hidden physics of fibrotic lungs. Okay, I want you to picture something. Imagine taking a piece of Velcro and just slowly ripping it apart. Think about that sound for a second. That dry, tearing crackle? That is exactly what a lung sounds like when its delicate, elastic architecture gets replaced by rigid scar tissue. You see, interstitial lung disease is, at its core, a disease of lost elasticity. And once you really grasp what losing that stretch does to gas exchange, breathing mechanics, and your chest exam, I promise everything else in this topic just clicks. Let's build this from the ground up.
So why do fibrotic lungs sound exactly like tearing Velcro? Clinicians didn't just pick that comparison because it sounds dramatic. It literally mimics the underlying physics of two stiff, adherent lung surfaces being forced apart. It's hands down the most accurate description we have, and it all comes back to the crazy mechanical changes happening microscopically inside the tissue itself.
Which brings us to the core lesion. Think about a healthy interstitium, that delicate little scaffold surrounding the alveoli. Normally, it's incredibly thin, super compliant, and essentially invisible to gas exchange. Oxygen and carbon dioxide just breeze right through it. But in ILD, that beautiful architecture gets completely wrecked by progressive scarring. The scaffold gets thick, scarred, and totally non-compliant. It literally resists expansion. And whether this happens because of chronic inflammation, an immune response, or just some totally idiopathic process, the physiological fallout is massive. And the real kicker here is how this thickened scaffold completely tanks diffusion. Oxygen suddenly has a much longer commute, facing massive resistance to cross that barrier. This is exactly why your patient might feel totally winded just walking up a single flight of stairs, way before their x-rays look even slightly alarming. It's also why a drop in DLCO, or diffusing capacity for carbon monoxide, is such an incredibly consistent early warning sign. It's a direct, real-time reflection of that thickened, scarred barrier.
Now, aside from ruining diffusion, that fibrotic lung tissue is just unbelievably stiff. And this loss of elasticity gives us a classic restrictive ventilatory pattern. It's basically the exact mirror image of an obstructive disease like COPD. So instead of airway resistance dropping the FEV1/FVC ratio, the stiff tissue in ILD just completely resists expansion. What does that mean for your spirometry? You get globally reduced lung volumes, but a totally preserved or even elevated FEV1/FVC ratio.
Okay, here is the secret behind that signature Velcro sound. Those fibrotic, stiffened alveolar walls, they actually stay collapsed for way longer during a breath. Healthy alveoli pop open smoothly and progressively, but these scarred ones, they stubbornly wait until enough pressure finally builds up to overcome that abnormal stiffness, and then, bam, they violently pop open, suddenly and sequentially, very late in inspiration. Picture thousands of these tiny, stiffed units popping open at the very end of a breath. That's your fine, high-pitched, late-inspiratory Velcro crackle.
And knowing these mechanics actually gives us a brilliant, highly practical cheat sheet. I mean, understanding why distinct crackles sound the way they do is way better than just rote memorizing symptoms, right? In ILD, those crackles are fine, they're late, and crucially, they do not change with a cough. Why? Because they're fixed structural changes, not airway gunk. Compare that to bronchiectasis, where the loud, coarse crackles do clear with a cough because you're moving mobile airway secretions. Or think about pulmonary edema. Those are coarser crackles that shift dynamically based on the patient's fluid stats. When you know the physics, telling them apart is an absolute breeze.
Also, crackle timing is a huge giveaway. Early inspiratory crackles, that points you straight toward airway diseases like chronic bronchitis or emphysema. Late inspiratory crackles point to parenchymal disease, like the fibrosis we're talking about today. Oh, and if you ever hear short, high-pitched end inspiratory wheezes, we call those pulmonary squawks. You need to immediately think of hypersensitivity pneumonitis, pneumonia, or bronchiolitis obliterans.
So moving beyond the stethoscope, age is a remarkably powerful first filter here. In older patients, idiopathic pulmonary fibrosis, or IPF, is far and away the most common cause. But if you have a younger patient, the differential shifts completely. You've got to start thinking about hypersensitivity pneumonitis, connective tissue diseases, drug-induced toxicities, or occupational exposures. Reflexively slapping an IPF diagnosis on a young patient is a massive clinical trap, and definitely one we want to avoid.
Now, mapping these causes to their predominant zones can drastically narrow down your differential before a single test comes back. And we have some great mnemonics for this. For upper lobe predominance, think Sarah has to be sick from chronic ankle pain. that covers everything from sarcoidosis down to ankylosing spondylitis. For lower lobes, use drugs cannot cure asbestosis. That neatly packages drugs, connective tissue disease, IPF itself, and asbestosis. We also see some really wild hypersensitivity triggers here, stuff like farmer's lung from moldy hay, bird fancier's lung from avian proteins, or even hot tub lung from inhaled water vapor. Nailing down these triggers is absolutely key to cracking the case.
Let's zoom in on IPF for a second, because it carries the worst prognosis. Getting the diagnosis right is non-negotiable. The framework rests on 3 solid pillars. First, you absolutely must exclude known causes of ILD. Second, you analyze the high-resolution CT, specifically looking for the classic usual interstitial pneumonia, or UIP pattern, which shows that telltale honeycombing and basal fibrosis. And third, pathological criteria via biopsy, but only if it's clinically required.
Speaking of biopsies, we need to talk about a massive game changer from the 2022 ATS-ERS guidelines. They updated the HRCT patterns into 4 tiers and introduced a brand new concept, probable UIP. This is huge. In practice, a probable UIP scan, when paired with the right clinical context, can now confidently support an IPF diagnosis. That means we can spare patients the heavy risks of unnecessary surgical lung biopsies. It's an absolute win for patient safety. And for cases where tissue is still needed, transbronchial cryobiopsy is now recognized as a less invasive alternative at expert centers.
Those same 2022 guidelines also formalized another incredible concept, progressive pulmonary fibrosis, or PPF. This classification is a total paradigm shift. It finally acknowledges that some non-IPF fibrotic diseases follow the exact same progressive, aggressive trajectory as IPF. And the payoff here? It means life-extending antifibrotic treatments, which were historically locked away only for IPF, can now be given to non-IPF patients whose disease acts just as aggressively.
So once you've nailed the diagnosis and classification, how do you actually treat it? Well, while modern antifibrotics like nintedanib and pirfenidone can't reverse the scarring that's already there, they do meaningfully put the brakes on lung function decline. But here's the reality check. The prognosis for IPF is often quite short, with median survival hovering around 2.5 to 3.5 years. Because of that, you have to pair these meds with early lung transplant referrals. Waiting too long is a major pitfall. Get them evaluated right at diagnosis if they're high risk. We support all of this with home oxygen, pulmonary rehab, and of course staying on top of vaccinations.
Also, really quick but vital update. We saw a major reversal in practice back in 2022. For years, the old-school thinking was that treating presumed silent reflux with antacids might actually slow the disease progression. But recent systematic reviews have definitively shut that down. Treating silent reflux does not improve respiratory outcomes, and it doesn't slow the fibrosis. So the explicit guidance now is, do not prescribe antacids for that specific aim.
Before we wrap up, I want to give you a golden exam tip that brings us all back to the patient sitting in front of you. Think back to your surface anatomy. The right middle lobe is only represented anteriorly and laterally, roughly between the 4th and 6th ribs. It has literally 0 posterior representation. Why does that matter? Well, if you're only auscultating the posterior chest, looking for those Velcro crackles, you are completely missing the right middle lobe and any pathology hiding out there. Always, always check the anterior and lateral chest.
All right, let's run this logic through one last time. Interstitial disease thickens and stiffens the delicate lung scaffold, which wrecks diffusion and restricts expansion. So the next time you hear that unmistakable crackle, you're not just going to recite a symptom list, you're going to picture exactly what is happening microscopically. Thousands of scarred alveoli violently popping open against resistance they were never designed to handle. That is interstitial lung disease, built entirely from first principles. But it does leave us wondering, if this tissue is permanently scarred, does the future of ILD treatment lie in just slowing the damage, or will regenerative medicine eventually let us build a brand new respiratory scaffold? If you found this explainer helpful, hit subscribe and leave a comment below so we can keep decoding the mechanics of medicine together. Thanks for hanging out and learning with me today.